Hello, before we get started, my name is Aaron Williams. I'm a physician, and I'm going to talk to you about Far-UVC light today. And just up front, financial disclosures, I have none directly or indirectly with any of the companies or with this technology in general, but it's just something that we all need to know about that needs to be in many, many places. But we're going to specifically focus on the ORs today, and let's go ahead and jump in because there's a lot to cover. So Far-UVC light, what is it? It's a new form of safe UV disinfection that, as opposed to other UV that can penetrate skin and human eyes, cannot do either of those things. And so that's where it's a real game changer, when you can use a UV disinfection light when people are present. And specifically today, we're going to talk about how it's going to give us breakthrough decreases in surgical site infections and specifically prosthetic joint infections. How we'll do it? By targeting the primary source, which is the operating room air, and administering safe and continuous disinfection before that lands, those particles in the air land directly in the surgical site or onto the things that are getting ready to go into the surgical site itself, in worst case scenario being those implants. Taking a look at this problem, prosthetic joint infections remains a major problem, despite all of our efforts. Incidence about 1.5% on average across all total knee and hip, for instance, leading to a tremendous increase in morbidity and mortality, even out to 5 years, double the mortality rate associated. Economic impacts can't be forgotten either. Huge impacts. We can at least say 100,000 roughly per infection, and also upwards of 400,000 if you consider the indirect costs as well in recent studies. An example scenario, if your institution does 1,000 joint replacements every year, that's going to be about 15 infections and about $1.5 million in cost to the institution up front. And the question is, are we not trying hard enough? Why do we still have infections? Everybody's looking everywhere. We're doing everything possible, thousands of studies, debates, meetings, conferences, all these things, and still we're forced to accept this baseline level of unacceptable. And it amounts effectively to surveillance. Now, we need that. It's very important to make sure that we don't have any process going backwards, but ultimately, they're still happening. They're still happening. Despite all this effort, though, we're punished as hospitals and also surgeons for these invisible enemies that we're doing everything we can to try to stop. So getting more specific here, early joint infections after the replacement is done, less than 12 months is what's considered. And we've known for decades that 2/3 of these are seated in the operating room before they ever leave. And of these, by far the largest proportion of those bacteria found in the wound reached it via the airborne routes. We know this, but why isn't the OR sterile? Well, what we put into it is, but when people are present, what we end up getting is air that's not that much more cleaner than is on the general wards of a hospital. And so how do those bacteria get into the air? Well, people come in, they bring in outside air, which has at least higher concentration than what's already in there. And when those people come in, they also bring skin, putting off about 1,000 squames per person per minute, with about 10% of those having some bacteria on them. Staph aureus, Staph epidermidis, big causes of surgical site infections. Additionally, we breathe. No matter how you cover yourself up, this is getting out as well. In addition to foot traffic kicking things back up, anything you touch in the OR that has contamination, any move we make, all of that is going to bring more back into the air. So do we really know the primary source of OR airborne bacteria and these infections? Well, yeah, it is indeed the air from people. We know that more people in the OR equals more airborne bacteria in the OR. Additionally, more airborne bacteria in the OR equals more infections. We have this down. Now, we've established this, that indeed more airborne bacteria is more infections, but also over time, the longer you're exposed, and we have this across multiple specialties, the higher the rate of infection. And so here, we've got longer operative times resulting in higher rates of joint infections, with each 20-minute increase in duration of surgery resulting in a 25% increased risk of infection. So we've established this now logically, but also scientifically now. Let's get into this. What is an exposure response curve? Well, it's basically the more of a dose of a medicine or a poison, the more of a response you get. That could be desirable, could be undesirable. In this case, the exposure is exposure to an infectious dose of a pathogen, and hence the more likelihood you are to get an infection, to be ill from an infection, the severity of that illness or infection, and also subsequently death in the worst case scenario. And so our unavoidable facts here for the operating room context is that more airborne bacteria exposure is more infections. So there's always a constant release of microbes into the air because people will be there. More time in surgery means more bacteria will reach the surgical site. More wound exposure, larger incisions, longer surgeries, mastectomies, heart surgeries among them, deficient host defenses if we're in a space that doesn't have much natural protection, and specifically for this talk, implanted materials being a huge factor to consider, because what will happen is those bacteria will get onto those implants and form a biofilm that no amount of antibiotics or anything in the blood can actually penetrate and get around. And it's part of why these are so devastating. Now, we've established this scientifically, the more airborne bacteria is that, and this paints a pretty bleak picture. Okay, we said they're unavoidable, and if we didn't have something to reverse this. We wouldn't be talking about it right now, but we do, because inherently built into these infectious dose response curves are the disinfection response curves, meaning that if we can get less airborne bacteria, we're going to have less infections. Now, let's just look at a quick schematic. This is how bacteria get into the operating room air, generally. Then they move around within the operating room air, either landing directly into the surgical site or into the things that are later going to go into the surgical site and then making their way in, none of which are good. So how do we try to limit that? Well, one, we try to limit the physical introduction of bacteria in the wound by starting with a sterile patient, sterile field, but also with sterile instruments, implants, coverings for all of us in the OR. And there's rarely breaks in technique, which we have to watch out for, but how are we getting contaminated if we're not actually touching the wrong things? So the second thing that we do is try to limit the introduction of bacteria into the air. This is baked into the way that we operate nowadays, is based on this premise. What do we do? A lot of things basically putting in sterile supply air, but then trying to decrease this in every which way we can to try to minimize it. Big topic of conversation. And third, there's still unavoidable bacteria getting in the air. What do we do with it once it gets there? Well, we remove the live bacteria from the air by trying to put fresh air inside. We do that a couple of ways, just kind of a haphazard blow it in, blow it out, which is really effective at decreasing the overall counts. And also, we try to direct it sometimes with what's called laminar airflow, pushing the air away from the operating room table and closer to other things, which is not always a great result. But at the end of all that, what does sterile accurately describe in an operating room? Well, not actually much. Once it's out of the package, you can label it sterile all you want, but it no longer will be very shortly thereafter, including the sterile field itself. Now, if you were to look around, we can find many studies, but basically the contamination is head to toe. Even the sterile setup table in the operating room is not so sterile. The gloves, we recommend changing them often because they get contaminated, and it's an easier thing to change than a lot of the rest. No time is really sacred either. Even immediately after draping, up to 20% of the gloves will already be contaminated before the surgery has even begun. If you look for anything that isn't contaminated, well, you're not going to find anything over time that isn't contaminated, because everything in there touches the air. Because, why do we have them? If we're trying to blow them out, well, the unavoidable bacteria are going to fly, but many of them are going to land places. They're going to deposit, get kicked back up, but only some of them are going to actually move straight to the ducts and get moved out of the operating room air without touching something first. And so you're moving around those bacteria with turbulent flow and laminar flow, you're diluting them. But you're also getting secondary consequences when you blow it away from the operating room table. Maybe you get a 6% contamination rate at the operative site, still not zero. But then in one study, upwards of a 35% contamination rate of the back table where all the instruments and implants are. So you're robbing Peter to pay Paul. Still, they're live bacteria to go in places. If we were to look at meta-analyses, there's been over 900 studies done over the last 50 years alone. They say, yeah, the air is really important. The infection potential is really important, but we don't have a clear answer on using one ventilation system versus the other. We just need to keep studying it. And if you were to look at the recommendations from the authorities, they're sometimes even conflicting, with World Health Organization saying don't use laminar airflow systems for joint replacements because it actually increases your rate of infections. Now, why do we have 907 studies and recommendations being inconclusive and often contradictory? Because airflow is unpredictable. Everything and every way each person does it and at which location changes that airflow. So you're effectively trying to manage chaos better, but you can only do that so well. Hence, we're limited. We're still looking for a breakthrough. So what's certain and predictable? Well, recent systematic review that the majority of airborne particles found in surgical wounds come from the OR air. So primary source is the air. There is continuous contamination of that OR air. Everything in the OR gets contaminated. The only questions are how fast, how much, and what distribution. You'll never be able to eliminate the presence of bacteria in the air. And the results of those conflicting studies on ventilation systems is the answer, because trying to control the flight path and deposition of dust and aerosol is always going to be highly variable, because the ventilation does dilute, but otherwise only moves those live bacteria. So the only way to decrease this inevitable risk is to kill those unavoidable bacteria in the air and or when they land on the surfaces before they land and can seed to cause infection and start growing. So this is where you get the, I don't really exaggerate to say, perfect solution meeting this huge problem. Far-UVC light giving us those breakthrough decreases, and it's giving us predictable continuous disinfection to match that unavoidable continuous contamination. Just using those bedrock scientific principles of more is more and less airborne bacteria is less infections. Now that sounds really good, but do we have some more evidence than that? Well, okay, let's look at a perfect study that actually matches this problem. Now, this matchup between Far-UVC is against the #1 cause of surgical site infections worldwide in Staph aureus. This study was published in Nature magazine 3 years ago. They blew Staph aureus into the air. They found steady state levels. They put these lights on up in the operating room, 5 lights shining throughout the operating room, through this room, excuse me, not operating room. And then they turned the lights on and they decided, well, how long are we going to wait? They waited 5 minutes. Let's see what happens. And here's what that looks like. Almost all of it is gone. Now, here's the even more amazing thing, and it matches this problem perfectly, that the Far-UVC, they kept blowing it into the air that entire time. So while you see this baseline close to 0 the entire time, they're still blowing it into the air, which is a perfect simulation of what we're talking about with airborne bacteria in the OR. So now you combine that and now you compare. When we talk about the disinfection response curve to what this curve looks like, it looks even better, which is pretty amazing. But then again, it is light, the speed of light, killing and penetrating these bacteria in real time within seconds. So, okay, that also sounds good, but has UV disinfection ever been used before in the OR? Yeah, in fact it has. It's been used in many applications for over 100 years. It has never not worked, depending on what your application is. It's been used, though, in the ORs for over 90 years, starting at Duke in the 1930s, Harvard for multiple decades starting in the 70s, and it's incredible results wherever it's used. You're looking at these numbers over here for this decreases. A while back, or even recently, you're seeing huge, dramatic breakthrough decreases in surgical site infections for 90 years. Looking at those studies since 1949, you've had between a 0.3 and a 0.9 surgical site infection rate, and that's pre-modern even with times. And ortho studies since 1980 alone, the average infection rate has been 0.65%, which is about a third of the national average. How did that start? Well, here, UV disinfection in the OR in 1936, J. Darrell Hart, physician, basically one of the founders and bedrocks of Duke Health as we know it, made worldwide headlines with his radiation that kills all germs. Now, what he did was, they looked at all their sterile processes. They said, well, we don't have any problems with our sterile technique, but we are getting seeded from the air. We lay out plates. The more hours go by, the more particles we get, especially when people are there. So what happens when we add UV? Well, our colonies go to basically 0. There aren't any. And that's what this looks like in the graph. So this is kind of the choice, ultimately, of what your bacterial contamination looks like with and without UV. But now, more specifically, does it do it also if it's also landed already? Or is it just in the air? And here's what happens if they wait 6 hours. There should be a lot. There should be at least in the 40s of these colonies. They give it UV for 15 minutes, and it is 0. It goes to 0. So that is what we're looking at and how amazingly this works. This is 1936. Well, did they get results? Okay, that's great in the Petri dish. Did they get results? Yeah. In 1938, they published results, a decent amount of cases, and they only continued on over time. We'll see that shortly. This is in the days before antibiotics, mind you. Before antibiotics. So these procedures, we were still measuring more surgical site infections and mortality at this point for some surgeries, like these thoracoplasties, 7.7% mortality rate. Radical mastectomies, they had over 30% infection rate, but no mortality in this small sample. What happens with UV? When they added UV, we now went to a 0 mortality with thoracoplasties, huge thoracic surgeries. And even more importantly, what you note here is that the radical mastectomy surgical site infection rate is 2.6% in 1938 before antibiotics. That is lower than most all published results to this day on radical mastectomies. That doesn't tell you something. It does. Now, here's 30 years worth of studies published by Dr. Hart and the same authors at Duke. So we've got an average of about 4% surgical site infection rate without UV. What happens when they add UV? They drop over 90%, and 0.34% is their infection rate. And this is in the days before laparoscopic surgery and small incisions. So compare that to today's numbers, and this is also likely to be far less. That's just absolutely incredible. What about, okay, that's 1960s. How about the 1970s? Yes, UV still works. Harvard picks it up. They do the same thing. And you see in this graph here, in this picture, on the left and the right, on the far sides, they weren't using UV during those times, before the patient went into the OR and then after the patient left. Those are basically the only colonies that grow. What did that look like? Well, their combined rate of infection on total hips and knees was 2.6%. You added the UV, you dropped almost 90% down to 0.29%, which is lower by far than the average of today. Now, how do we know that these cross over? You're talking to us about the old UV, but what about the new UV? Well, Far-UVC 222 is a different substance using krypton rather than mercury to shake that into electrify it basically, and then it spits out a different wavelength of light, like a different tone, effectively. And we have basically correlations and equivalent doses well established in the lab and otherwise between these two. So we know how much equals that, and we can use far more of the Far-UVC than we can UVC in the ORs anyway. It's equally effective against nearly all pathogens, and it's more effective against many. And here's the kicker, it's safe for humans. So whereas back in these times, and part of the slowness for the adoption, only catching on in a few places, was everyone had to cover every inch of skin, their eyes, special goggles, everything. So it was pretty miserable for everyone to be doing this, even though maybe we should have been for a long time. That said, now there doesn't have to be any of that because the Far-UVC is completely safe. In fact, it's extremely safe. It's been tested extensively, extreme doses to people's skin, tested long-term studies on human skin, on mouse skin, on human eyes, over 3 years worth of studies, never been able to harm a human or an animal. It's much safer than sunlight, that is not an exaggeration, and the skin cancer risk is zero, effectively zero. Now, what about the modern day? Have these results really transferred over? Can I really trust that this is going to work the way that you're referring to? Well, we still have modern day breakthroughs. 2007, here's a study we need to really highlight. This is an amazing study. One surgeon, 6,000 total joints over 19 years. First, he used 5 years of the laminar airflow trying to blow it away from the operating room table, had a 1.77 infection rate. Then switched that off, turned on UV lights instead, and went to the other ventilation. Now has a 0.57% surgical site infection rate now. That is a 68% decrease with modern day techniques, technologies, ventilation systems, everything. So now we're coming full circle. So we do know that less airborne bacteria is less infections. And in fact, what was the number we saw from these decades ago studies? 2/3 of the infections are from the operating room air. We nearly see a perfect match with that 68% decrease in surgical site infections in that amazing 2007 study. You see why these things all correlate. Now, if you look at your different options, OR robots work really well, but everyone has to leave the OR. It can harm people, and it leads to increased turnover times, and they cost a lot of money. Looking at whole room, it is amazing, should have been using it, but it is a hassle. And laminar airflow systems, still pushing around live pathogens. We've proven that that can't be the final answer. Far-UVC gets every box checked. Cost savings estimates, you can go through your own. We're not talking about carpal tunnel surgeries here, but for those surgeries that we kind of referred to and could get in more depth with it, you're going to save money likely if you have a decent volume of these surgeries that have infections and that are clean surgeries, not in bowel or GI tract, etc. You're going to have probably savings and make money in your first year off of these. These lights take no more energy than an LED light bulb. And you're going to be spending your time doing new cases rather than losing money on redo cases, let alone mentioning the PR that you're going to have from protecting your patients with the newest amazing technology to keep them safe. So, summary. Infections are still a major problem in surgery and in joint infections. It gives us the opportunity that we haven't had before to give real-time disinfection of the air and the surfaces in and around the surgical field and everything, destroying the most common bacteria and all others. We have many studies, we just didn't have time to go through, on superbugs, on drug-resistant bacteria, escape pathogens, you name it, it kills them all. Has all, specifically to the OR, all those benefits of the other UV applications without any of the drawbacks, safe for exposure to humans, no risks, hassles, compliance burdens to the patients or personnel, decreased infections, better patient outcomes, and significant cost savings for the institution. So, in summary, this needs to be everywhere. The question is, which institutions are going to take this and run with it and see these obvious results that will happen once they install these and get these lights running continuously? Thank you.